EM board bombs.
Welcome back to EM Board Bombs. It's another episode with Dr. Briggs and I where we're full of high-yield knowledge for the boards and your clinical practice. Today, we've got something a little bit different for you. We're going to talk about some diagnoses that maybe aren't what they seem, see if we can trick you so that you don't get tricked later on. These are some cases that look benign until they're not. And if you miss them, you're going to be in trouble. So let's
trouble for
get
the boards
going.
and in real life. Both sound awful.
Yeah, definitely.
And Blake Briggs here. Happy to be here with you, Marlena. Dr. Hussein not with us. He's currently working on crypto investments. Just joking. We don't know if he's into crypto. I don't think he is, but he has a lot of interesting hobbies, that's for sure.
You might have Iltifat coin.
That'd be very funny. Yes. So we're Blue Collar EM Podcast. We tell you what you need to know for the boards, and we've gotten such great feedback. Thank you for everyone that listens to us. I'll have people come up to work randomly and mention, hey, I listened to that episode. It was pretty good. And we always get great feedback, so please keep the feedback coming. And we are very, very, very appreciative of the people who listen and enjoy our content. And we hope to continue giving you the type of content that honestly just speaks to a busy person. There's podcasts out there that do hour-long sessions, and that's excellent. They're much smarter than us, and they talk about the studies and the interesting p-values and the interesting pathophysiology. And this is not that podcast. This is a podcast that will tell you what you need to know, get yourself out of trouble on shift, as well as for the boards, and hopefully walk away feeling a little bit more practically smart, as I like to say to people. I'm not a smart person. I'm just practically smart. In practice only. Just try to be intelligent. So, again, check out EM Rapid Bombs. That is on Spotify. It is on every major podcast platform. If you go to our website, emboardbombs.com, it's one-click sign up for Rapid Bombs, the premium podcast. It'll basically prepare you as your only resource needed for board studying. Let's repeat that. Only resource needed. You don't need to do thousands of questions on a Q bank anymore and sit there and turn into a zombie. You can go out and go for a run or a walk or a bike or walking your dog or other animals. Said animal. Don't exclude anyone. And you can learn a heavy amount of stuff in terms of your board practice. Tell you what you need to know for the boards and for real life. We'll give you coaching, tell you what within 2 minutes, what the wrong answer is and how to pick the right answer, what stands out as the right answer, what are the buzzwords, if there are any, how the boards are going to ask you the question. No one is doing that. We're the only specialty podcasts, not just emergency medicine, but any field that is giving you that type of resource for such a cheap cost, less than the cost of Netflix, probably less than the price of gas too, as we're filming this. So
yeah,
pretty cheap.
Definitely.
Pretty cheap, so check it out. Yes. Cool. So why don't you dive into this and give us a stem here as we talk about these mimics, which is such a fascinating concept. I love this idea you have.
Yeah. So a 52-year-old male with diabetes presents with left leg pain and redness for 2 days. He states that he has had worsening pain despite taking his oral antibiotics that were prescribed yesterday for a diagnosis of cellulitis. At first, he thought that maybe the worsening pain was just due to the emotional suffering that he's having because of high gas prices recently. But then his wife said, I think maybe it's more than that. You should go back to the ER. So here he is. On exam,
his wife's with him, which is always a red flag.
Right. Yeah. His wife actually brought him here. So you know it's real.
Yeah. Huge red flag.
On exam, the skin is erythematous and warm, and there's mild swelling. There's no obvious crepitus. However, he definitely appears uncomfortable, and he's tachycardic. Which of the following is the most concerning feature for a necrotizing soft tissue infection? Is it A, erythema? Is it B, warmth of the skin? Is it C, pain out of proportion to the exam? Or is it D, mild swelling?
The correct answer is going to be choice C, pain out of proportion to exam. So there are like two conditions in medicine that the answer if it's like describing that condition and the answer choice is pain in proportion to exam, you pick that answer. That is the correct answer. It might be the correct answer of all time on any type of board exam. That or start CPR, the two correct answers for everything. And so correct answer is C, pain in proportion to exam. The other condition, by the way, is compartment syndrome. Hopefully you remember that, dear listeners. So this is such a classic board setup, and in real life too, I've personally have dealt with these situations. If someone on oral antibiotics, they either got it from urgent care, maybe they went to the ER a few days before, or their PCP, and they got a good antibiotic. Sometimes it's, the wrong antibiotic, and you're just kind of like chuckling inside. You're like, okay, I'll switch this up and you'll be good to go. They're on like Levaquin for like cellulitis or something. But other times they're on the right antibiotic, like doxycycline, great choice for skin soft tissue infections. Same with Bactrim, trimethoprim sulfamethoxyl. Sorry, we're not sponsored by Bactrim.
Oh, look at you!
But they're baiting you. I know, fast, right? Still can't say Precedex. People make fun of me at work for that. The generic name. Still can't do it. I don't know why. Haney made me like out a fool that last episode. So they're baiting you with cellulitis on this, but they want you to recognize a deeper soft tissue infection, which is neck fasc. Now, the presentation of neck fasc is quite variable, but the early recognition is the most critical for most salvageable, tissue and limbs, honestly. So neck fasc is often diagnosed as cellulitis. In one study, they showed up to 75% of the time, which I'm laughing. It's tragic, but I'm laughing because it's like, this is such a real issue in terms of dismissing their exam. And the key here is that neck fasc can look exactly like cellulitis in every way possible. Same redness, same warmth, same swelling. But the differentiator is huge. And what is that?
Pain. It's so painful.
Yeah. And the problem is that sometimes we're dealing with patients that may be older, so they don't have the best, sensation exam. And they also could be diabetic. So many of these patients, I feel like personally I've seen are nursing home or some type of skilled facility, assisted living patient. Sometimes they're non-ambulatory. Sometimes they're insensate in parts of their body or neuropathic. And that limits your exam. But it's so crucial to even an unassuming patients to expose that area and always visualize with your eyes the entire area. Don't just have them lift up the pant leg and you're like, oh yeah, it looks like redness, and you didn't see that it tracks all the way up into the thigh and there's a fluctuant abscess, that sort of thing. So why don't you break this down, the high yield comparison between the two again?
Yeah, so break it down here. So cellulitis, superficial skin infection. It's a gradual onset usually. The pain matches the exam. It's mild, moderate pain. And the patients look relatively well. They're not usually tachycardic. They're not usually, writhing. If they're a nursing home patient, they're not going to come in like severely agitated. Whereas necrotizing fasciitis, this is a deep soft tissue infection. Remember where the fascia is. It's a rapid progression, really rapid. Like it'll change in front of you if the patient's in the ED with you for longer than an hour, and the pain is going to be out of proportion to exam. Systemic toxicity early, like the patient in this question stem, he was tachycardic already and he'd only been symptomatic for a day. So look for that fever, that tachycardia, that agitated patient. This is why we always advocate for doing a full skin exam on agitated nursing home patients that come in sick.
Totally. Yeah, totally. And just to clarify here, people say neck fasc a lot or necrotizing fasciitis, and we're using that for the simplicity of this podcast here. But neck fasc is any type of severe soft tissue infection of the subcutaneous skin and muscle fascia. And it's rare, but the mortality rate's like up to 35% of patients. Insane in this modern day era that is that high of a mortality rate. That's like much higher, leaps and bounds higher than an aortic dissection, which hint, hint, we may talk about in the future. The severity of this illness is because of that aggressive spread, as Marlena said correctly, and it spreads along the tissue planes of blood-deprived fascia. So neck fasc can affect all parts of the body. The most common areas, extremities and perineum, genitalia. And yeah, we're using this term neck fasc a lot, but it's really just on the spectrum of other necrotizing soft tissue infections. You can definitely have necrotizing myositis. You can definitely have necrotizing cellulitis in a weird way. It's just like a deep soft tissue infection. But anytime it crosses that fascial plane, it's considered neck fasc. And when you're trying to diagnose this, some people talk about, getting the labs, and let's check a lactate. Let's do a Lorraineic score, whatever it's
Oh
called.
my gosh,
Let's
the most useless score.
Yeah, a useless score. Uh, or get some X-rays and look for gas, or get a CT and look for, how deep the infection goes. Can you talk a little bit about that and the utility of those tests and scoring systems?
Yeah, absolutely. So, yes, you can know those things. But I would just want to emphasize that neck fash is a clinical diagnosis, and you shouldn't wait for those late findings to make the diagnosis because all these things that we associate with it, like even on exam, the things like crepitus, bulla, necrosis, like visual necrosis to your eye, those are late findings. So if you're waiting to see those, you're already late, which is why it's important to know the early thing, pain out of proportion. And the other red flags like the fever that we talked about earlier, the tachycardia, the failure of outpatient antibiotics, and the risk factors. Like in this question stem, the patient was diabetic, a patient that's on immunosuppressant medications, if they've had a recent surgery, if they're an IV drug user. So, if you do get labs, you might see like an elevated white cell count, an elevated CRP if you're still getting CRP for whatever reason, a lactate, sure, hyponatremia. CT may show gas in the tissues, but I hope if you got a CT, maybe it was just because you have already talked to surgery. And why would you have already
Totally.
talked to surgery, Blake?
Because this is a time-sensitive diagnosis. So understanding that these patients need to be consulted early for surgical management, and you've already given antibiotics at that point, and then you're talking to the surgeons. And honestly, this question comes up a lot on the boards, and people ask me too. They're like, "Hey, what's the correct answer when I get this question on boards?" And they're saying, "Hey, we have neck fash on the clinical stem, and it's saying what's the best next step?" And you're wondering, do I pick the IV antibiotics or do I pick the surgeon? Call the surgeon question. And the boards have to be a little bit fair. They usually say something like, "What's the best immediate step?" And it's start antibiotics. And then usually the question will reframe and say, "What's the definitive next step?" or "What's the final step?" or "What's the definitive treatment?" That kind of thing. Whatever. And the answer is call surgery in that case.
Yeah, so read that question carefully. Like, what is your definitive treatment? What is your definitive next step? What is your immediate next best step?
Totally. List the red flags for a neck fash that would come up on the boards and partly real life too. What is standing out to you is not just cellulitis.
Yeah, so board favorite red flags for neck fash: pain out of proportion on the exam, a rapid progression of symptoms, systemic signs like fever, tachycardia, and hypotension, failure of outpatient antibiotics, and skin findings that evolve quickly, often in front of your eyes.
Awesome. Yeah. So the classic trap would be the patient will come in with quote unquote cellulitis, they get antibiotics, and they come back worse. And it's not just treatment failure, that's just, a deep infection until proven otherwise. I will say, as a plug, in patients who look great and they've only been on the antibiotic for like a day or two, and you don't think it's neck fash because it's not pain of proportion, they look fine. In that case, so often in my career, I have seen those patients fail because there's an abscess no one drained and no one looked for it because it wasn't very obvious on the skin. And pretty much every single patient has cellulitis and there's a focal area of redness. I will 100% put an ultrasound probe on it and look and see, is there fluid collection here? Is it greater than like a centimeter of fluid collection that needs to be drained? And that's because the antibiotic isn't working and it's not really doing anything because you haven't penetrated that abscess wall. So I will say, as an aside, as an abscess perspective, always think about an abscess in a patient who comes in with treatment failure with cellulitis, or they're not getting better even after like 2 days of antibiotics. So that's a whole different story. But in general, yes, whenever someone comes in with skin soft tissue infection, they're not getting better after 2 days. Usually 48 hours is that unofficial mark of saying this is when people should start turning the corner, not 1 day, but 2 days. And it's that point they're coming in. You're thinking about a deeper space infection or an abscess. So again, skin exam can be totally unassuming in these patients. So why don't you do a rapid fire review here, and then I got a bonus section I want to quiz you on.
Oh, okay. All right. So rapid fire review. So neck fash, It's a deep infection. It's a surgical emergency. Your early signs can be subtle, but pain out of proportion is a key clue here. Imaging can help you, but it cannot rule this out. So your clinical suspicion is important. Treatment is surgery, definitively, plus broad spectrum antibiotics that you should initiate immediately.
I feel like this just harkens back to the fact that every skin soft tissue exam, nothing you do with lab or imaging helps. And by imaging, I mean, yeah, do an ultrasound, look for an abscess, look for source control, totally. But this whole like, oh, let's get a CT, oh, let's get some labs, see how basically using imaging or labs to grade severity is worthless in skin soft tissue infections. And that may be a bold statement, but so often we use this crutch of like, you look at an extremity and you're like, oh, it looks pretty red. Yeah, it looks probably cellulitis. Let me get some labs. I mean, why? Like, what's the point? Like, like if you're concerned, you're concerned. It's either just cellulitis or you're gonna get antibiotic, they're gonna go home. Because most people with cellulitis can go home, like the vast majority should go home. Or you're thinking, is it neck fash? And I'm calling surgery. I mean, the difference is so stark. And yeah, I know there's an in-between of like, could it be an abscess? But still, even you drain the abscess, they're going home, probably on antibiotic. And so I don't personally get labs on any of these patients. Unless you're considering that you look in the room and you're like, yeah, this is going to be an admission, then yeah, I'll get the admit labs because the hospitalist wants it. But I don't know what you think about that, but I guess it's just silly to me that we even think about, even in neck fash, you're like, okay, let me get a white count, let me get a lactate. Okay, why? Like, what does that matter in terms of your definitive care?
I totally agree. If I am getting labs, it's literally only because someone is going to trend them and wants me to get them so that they can trend them. It's not me.
Trend things.
It's not me.
These are good labs to trend. CRP,
Yeah.
ESR, yeah, all those. Yeah. Anyway,
It's
okay, bonus
no
quiz for you.
utility to me. Yeah, go
Exactly,
for it.
same. What are the acceptable antibiotic regimens in patients with neck fash? What is your go-to? Hopefully our listeners know this already because you have to know this for the boards too.
Yeah,
what
you
is
definitely
your go-to antibiotic regimen?
definitely do. Okay, so the house wine, as I say, for me, for neck fash, I like
What does the chef recommend?
Yeah, the chef recommends the Vosin, which is the vancomycin plus the piperacillin tazobactam plus the clindamycin. So that's the threefold. And you can use a couple different things for each of those. So
Yeah, you can sub out.
in
The chef is okay with stepping out.
The chef is okay with subbing out. So if you do not want to use piperacillin tazobactam because the patient has anaphylaxis for reals, you can use a carbapenem.
Can't challenge that.
It's fine. Don't challenge that. This isn't the time for that.
Yeah, don't challenge it.
So you could use a carbapenem instead of the piperacillin tazobactam. And then instead of the vancomycin, you could use the daptomycin, but you want to have some activity against MRSA there. And then the clindamycin is really important here. And is sometimes I feel like it'll even ask you why the clindamycin. And that's because
I love that.
Yep, decreases the toxin production caused by this invasive group A strep. Yep.
Okay, let's say bonus for question further here. If our listeners get this, then you're ready for boards. Let's say someone was at the beach and they were walking in like a lagoon area, like shallow water, tides coming in and out, and they have a puncture wound over the leg, and then they come into you, and you've ordered antibiotics, everything you just said they've ordered. What additional antibiotic you need to add in there?
Oh, this sounds like they may have some salt or brackish water exposure, and in that case, I want some doxy.
Doxycycline. And you're covering for?
Vibrio vulnificus.
Perfect. I love it. Love it. All right, cool. So, hey, if you're a Rapid Bomb subscriber, then you're in for a real treat. We're going to do similar story like this, a classic chest pain mimicker. As in, you're thinking about differential for chest pain. You're going down this classic road of this one classic chest pain diagnosis, but you have to stop yourself, check yourself, and think twice about a completely different route you need to go down for some subtle physical exam and historical findings. So if you're Rapid Bombs subscriber, you get access to this automatically. If you're not, well, you're missing out. And if you like this format, then you're missing out on some pearls for real life as well as the boards, those hints that they'll subtly drop that you can completely miss if you just don't read the question correctly or think about alternative diagnoses. So again, if you're rapid bombs, tune in, you'll see that drop.
And if you want to sign up for EM Rapid Bombs, remember, just go to our website. It's easy to get there, emboardbombs.com.
See ya.